Well, I'm Dr. Rosso, a dermatologist in Las Vegas, Nevada, and also very, very proud of the Derms and Conditions podcast, which I've been a part of from the very beginning. And today we have a very special Derms and Conditions podcast program. It is a Tea with Dr. D. So that is a special video program where we utilize graphics and we pick from the best of the best. And that's why we have with us today Dr. Jason Hawks, who is co-owner, chief scientific officer, and a principal investigator at Oregon Medical Research Center, OMRC, in Portland, Oregon. He's also on faculty at the Oregon Health and Science University, also in Portland, Oregon. So he's teaching, he's seeing patients, he's doing it all, and he understands what's going on. That's why we have him here today. So, Jason, thank you so much for being with us today.
I'm happy to be here, Jim. Thanks for getting me back.
So, as we talked about when I called you to invite you to do this, one of the things that I've been concerned about was there's a lot of information that's talked about with mechanisms of action, and as new drugs come, obviously there's a focus, especially on industry, on what's going on with their particular therapy, and things get put into buckets, forgetting that the human body does not necessarily read this material, and it doesn't necessarily work in that way, but a lot of what we discuss are different types of inflammation like Th1, Th2, Th17, and also different cytokines. And I'm a firm believer when I hear someone say that such and such a cytokine is dominant, I'm a firm believer that there is no one dominant cytokine. They all play individual roles. So that's why I'm coming to you, because I've seen you talk about this and present this. So can you clarify this particular situation?
Yeah, you bring up a lot of important points. And the first thing you brought up was we try to force the immune system into these buckets. And I always like to kind of start these talks with those buckets are arbitrary. They're probably oversimplified. We know that the immune response, for example, is quite dynamic. There's overlap, there's redundancy. So I think we have to step back and say, what was the purpose of these buckets in the first place? And they were really designed to help us say, well, what was this disease doing relative to this disease? Did they share a lot of the same signals? Were they completely different signals? And that got us into the Th1, or I don't like Th1 either. I'm with you. The type 1 immune response, which we'll talk about, versus type 2. And you see a lot of the old textbooks, historically, even the papers, make this dichotomous Th1 versus Th2. You read that. And I think the purpose was to try to say, are they similar or different? And then we quickly added layers where we start getting these responses which weren't type 1 and not type 2. And that was really the historical development of the type 3, or what was traditionally called Th17. And so we started adding layers, which again got back to that complexity. And then you start getting the targeted therapies. We have to go back to this key concept, go back to the foundational aspects of what these different responses do and why they're there, and then work our way towards the conditions.
So what I'd like to do in the time we have, because we are going to revisit this again in the future, we're not going to try to digest all of this in one program, in one Tea with Dr. D. So let's start with Th2. And if we can go to the next slide where you talk about Th2, and we'll look at the role of the individual cytokines, because they all work together, right? They're like the members of a band, and the entire band is good, right? So can you walk us through this?
Yeah, and I think in the first slide, what it's really showing is that key concept. I call it the immune synapse, right? Or the dendritic cell synapse, where you have the dendritic cell talking to these naive T cells. And these naive T cells haven't developed or differentiated into having really a characteristic response, right? Once we get to Th2, for example, or type 2 inflammation, which I think is a better term, because Th2 implies helper T cells, CD4 positive cells. But we know that, like in psoriasis, for example, CD8 cells are important. So we often talk about these as either T2, which implies the CD4 and the CD8, or just type 2 inflammation, which I think is probably a better term. And what we're really getting at is this disease or condition that we're talking about, is it mostly these cytokines that tend to fit better in this type of immune response? And that's really what we're trying to get to. So we're talking about these naive T cells that undergo differentiation. That's where they start to pick the type of immune response they're going to drive.
So it's almost like someone early in life that doesn't know exactly what they want to do, and
Yeah.
then they meet someone that inspires them and gets them going. And the person they meet here, what I'm looking at, is interleukin 4 that starts to
Yeah.
direct them on a path. And they go, okay, that's what I want to do now. That's the path I want to go on. Am I thinking about that in the right way?
Absolutely. So you've heard some of these analogies. Maybe it's a medical student, doesn't know what specialty, and then they get these exposures. They start to differentiate and say, this is what I'm going to do. I'm going to start making these particular cytokines at high levels, and that's going to influence the landscape of the health, right? If it's type 2, it's going to start to drive some of these atopic conditions. If you're more type 3, you're going to drive psoriasis. So one of the easy ways to simplify this for clinicians is you can really remember 3 key cytokine signals. And those are going to be the signals that are going to push you towards type 1, type 2, or type 3. So IL-12 is going to be that more type 1 inflammation. IL-4 is going to drive that type 2. And IL-23 is going to drive that type 3, which is, classically plaque psoriasis, for example. So it's an easy way to kind of remember 3 of the predominant signals really driving differentiation to 3 of the main types of inflammation.
So explain to me what's happening here, because one of the things I think that's important because of, interleukin 4 being involved with different receptors, peripheral and central. So explain that, because I think that makes a big difference where when you're inhibiting interleukin 4, that's why you're extending into some of these systemic diseases that are associated with atopy as opposed to just the skin, the atopic dermatitis, correct?
Correct. And this is a great place to kind of debunk some of the myths that we commonly hear. So when you take these one of 3 signals like IL-12, IL-4, IL-23, those are going to be regulators. So they're being made not by the T cell, but by other cells like the antigen-presenting cells or the dendritic cells. So just like in psoriasis, those dendritic cells are making IL-23. Here you've got these cells making IL-4. And that's the signal that's taking that naive T cell into the differentiated type 2 cell, that cell that's going to make high levels of IL-4, 13, 5, and 31. So in the presence of IL-4, we're starting to get that differentiation. Now, as you see in the bottom left of that slide, that really happens in the lymph node for the most part, right? This is where those cells, those naive cells come in contact with that dendritic cell. Now, whatever set that off, whether that's genetics or an exposure to the environment, the dendritic cell is teaching that T cell how to be differentiated to go out and make high levels of these type 2 cytokines, which is what characterizes that T cell as being a type 2 cytokine. Now, what's interesting on the receptor side, which is at the bottom, is once these cells go back into the circulation, they're going to start making high levels of these type 2 cytokines. What's interesting with IL-4 is that it's the only one of those 4 cytokines that drives the differentiation. So one key point is that the T cells don't have an IL-13 receptor and they don't have an IL-31 receptor. So you really can't get to these other cytokines without IL-4 driving that differentiation. And once you get into the sort of, I call it the kind of the master computer within that lymph node, that's the concept of what I put in red, central immunity. So inside really hematopoietic cells are expressing the IL-4 receptor. That's your bone marrow. That's your immune response, really in that centerpiece, that real central immunity, that master computer, really driving up the whole immune response around this type of inflammation. IL-4 can do that central computer, but it also can be expressed in tissues. So it can affect keratinocytes. It can affect lung tissue. And IL-13 is different in that way, in that it doesn't affect central immunity, but it's the main driver of the effector response, or that predominant response in the skin. Because there you see in the skin, for example, much higher levels of IL-13 versus IL-4. That doesn't make it more important, but its job is to drive disease at that tissue.
So you have a band. Somebody's got to play guitar, somebody's got to sing, somebody's got to play drum. They're all extremely important. And
Right.
that's what we're pointing out here. So I'd like to go to the next slide.
Well, before that
I'm
one,
sorry.
Jim,
Go back. Okay.
I think
Go back.
you brought up this question about, sort of relative expression. I think the one point to drive home here as well is that why is IL-4 levels a lot lower than IL-13, for example, in the skin and atopic dermatitis? Well, that's because IL-4 has a very high affinity for the IL-4 receptor. So you don't need a lot of IL-4 to have this profound effect. And so one of the myths is that, well, IL-13 is more important than IL-4 because of the expression levels. But we know that's not true in psoriasis, for example. IL-23 is expressed at much lower levels than IL-17A and F. We know, for example, IL-17F is at very high levels, and yet we have these dramatic responses in patients when we block IL-23. So it gets at this point for IL-4 really regulating and orchestrating the differentiation. We have these other cytokines like IL-31, which predominantly drives the pruritogen effect, really driving that itch response. And we know IL-5 is really pulling in that chemotaxis, recruiting eosinophils into tissue. So to your point, they're playing different roles. So we don't want to assume just because one's higher that it has a more important role. You need these together. And I think when we get into the next slide, it starts to get at, well, what does IL-4 do that's different than IL-13? And how are those two different from IL-31 and IL-5, for example? So now we start to appreciate not one being more important than the other, but what does it do that makes it unique? And then how does this play out in the conditions that we see in patients?
Okay, so let's move to that next slide. So I'm thinking about it like IL-4 is sort of like the quarterback. It needs a wide receiver, it needs a blocker, it needs a running back, a tight. So everybody's playing a role. They're all important, right? And
Right.
that's where we get these things that are this is dominant, that's dominant. And I understand those messages, but the bottom line is they're not accurate to what's actually going on in the immune system. So this is a great slide. I love this slide that you put together.
Yeah, so this slide, I think, really drives home the key points. And one of the key points right away is that IL-4 and IL-13 have a lot of overlap. So you see the blue and the purple overlap together. And that makes sense with what we know about these different cytokines, because they're probably about, maybe between 25 and 50% homologous. So they're very similar, and not surprising they can bind to some of the same subunits to drive some of the same effects. So together, they're actually more powerful than alone. So they do have a truly synergistic effect. They're very powerful at driving this pro-inflammatory response. They can drive inflammation. They drive keratinocyte proliferation. They sensitize the nerves to itch, right? They recruit other cells into the skin. And so when we start to look at those responses, we see that IL-4 and 13 blockade together has a greater impact on that immune response than, say, just blocking IL-4, which didn't really pan out clinically. And we start to see the limitations of IL-13, where it works quite well in atopic dermatitis, but very interestingly, doesn't have other indications. So there must be some unique functions that we add together with IL-13 and IL-4. And I think we start to see that play out in diseases. So for example, if you look at the top part of the column for IL-4, you see things like increased expression of IL-13 and 31. So again, that's that master regulator driving that differentiation. But then you see unique things like impact of the IL-31 receptor. We know that most of IL-31, or the vast majority of IL-31, comes from differentiated T cells. So again, we had to get there through IL-4. Other cells aren't making high levels of IL-31. And then one of the most unique functions that I think really came out in the last few years is that IL-4 is driving isotype class switching. That's how we get to IgE antibodies and also IgG1 and IgG4 antibodies. So that clearly
So
has a
what that
role.
means is
Yeah.
it's converting, is it from IgG to getting more IgE expression? Is that what it's
Well, we're
actually
coming
doing?
mostly from the like IgM, for example. So
Oh, okay.
we're starting, and one of the ways that this happens is that IL-4 actually can drive the activation of B cells. So one of the markers that correlates with activation of B cells is CD23. And we start to see the driving of the activation of these B cells, which can start making new antibody types. And so we know that if you get rid of the IL-4 gene, for example, we don't really get a lot of IgE. So that gives you a unique function. Again, saying what's the difference here? 4 and 13 together, and even 13 can really drive a lot of skin inflammation. But we're missing out on diseases like chronic spontaneous urticaria or bullous pemphigoid, where there's a very clear autoantibody link. You don't get that with IL-13, you get that with IL-4. So again, it shows the unique roles. It shows that together in conditions like atopic dermatitis and probably even prurigo nodularis, we're driving some of this clear inflammatory function. And then we move to IL-31,
Yeah, I wanted
where,
to get to
yeah,
IL-31 because we do have an agent that inhibits IL-31 in and of itself that's approved for like prurigo nodularis and atopic dermatitis. So isolating inhibition of just that one cytokine has an effect. So walk us through IL-31 because I think it's a very interesting discussion.
yeah, so IL-31 is interesting in that it is, again, predominantly made by the differentiated type 2 cells that went through that IL-40 or IL-4 teaching process. And so once we get to these differentiated type 2 cells, they can make high levels of IL-31. Now, IL-31 can also be produced by nerves. So again, this gets back to the oversimplification. We're talking about T cells as driving everything, but other tissues, keratinocytes, nerves, they can also produce peptides, which can drive inflammation. So, of the difference between these different cytokines here, IL-31 is what we would call a true puritogen. It's really a potent driver of itch, and it can also be produced by the nerves. But what we don't see with IL-31, which you see with IL-13 and IL-4, for example, is you don't see its ability to really regulate inflammation. So one of the potential downsides to blocking effector cytokines is you might hit its primary function. But if you have a condition, for example, that has itch and inflammation, then you may dissociate those two things. You could hit itch and let the inflammation persist. Or, as we've seen in some other studies, you may hit itch and have actually some worsening of that inflammation. So by hitting itch versus inflammation like we do with IL-4 and 13 as a primary impact, we're starting to tease out some of these clinical diseases that are maybe driven by itch first, that inflammation comes second, as opposed to a condition that's primarily inflammatory that also has secondary itch. And so this has been very interesting to tease out where this fits together. And I think the impact of IL-4 and 13 blockade, for example, is that you're going to drop levels of IL-31, but we're not sure if the reverse is true. We're not sure if you block IL-31, can you really reduce IL-4 and 13? Those clinical studies haven't been done because they were masked with topical steroids. So that scientifically is an unanswered question. And then you see with IL-5, very different than the other two. It's primarily an innate immune response rather than an adaptive immune response with T cells. This innate response is to help recruit eosinophils into the tissue. I'd say it's very similar to something like IL-36 or IL-1, which is recruiting in neutrophils, for example. So it's going to have the most narrow scope, but still one of those cytokines made by these predominantly these differentiated type 2 cells.
So what I'm hearing, the bottom line of all of this. And I think the beauty of this is people can go back and watch this and listen to this and digest it if they can't get it in one take. Because you didn't get this in one take. This is years of reading and analyzing and studying that you put this together. Is they all play an important role, and they're all working together. So we are going to remember that there are things other than T2. So we got to wrap this up, but if we can go to the next slide and give a little preview, a little trailer to what we're going to talk about in the next time we get together and talk about this, where we're looking more at some other disease states like psoriasis.
Yeah, so I love the point you made. It's not that one therapy is better than the other. Our job as clinicians is to see the patient in front of us and say, what's going on? Do they have inflammation and autoantibodies? Do they just have skin inflammation? Do they have predominantly itch? We're trying to match the right therapy to the right patient. That is the goal of medicine, that personalized care. And now with all of these therapies, I would say, and I've said this over podium, that you really can't be the best clinician without learning some of the science, because as you start to think about how these medications work, you're trying to tailor that to our patients. And when you have these patients with a broad range of type 2 diseases, your approach should be different than if you saw a patient with just one isolated chronic condition. So this is getting back to making what I love. My background's in the translational immunology, is how do we take this science and apply it to patients? And what we're getting at in this part 2, we'll come back and do, is how do we see patients for the type of inflammation that they have so that we can start to explore what therapy might be best for them. We're talking about type 1 inflammation or T1 inflammation, which is really a lot of the autoimmune conditions, lupus, psoriatic arthritis, some of the allergic contact dermatitis responses, inflammatory bowel disease, things that respond to TNF inhibitors, for example, versus type 3 inflammation, which is really, I think, prototypically plaque psoriasis, not only plaque psoriasis, maybe a little bit of psoriatic arthritis, just showing that one disease can kind of end up and have two types of main primary immune responses, and then say things like ankylosing spondylitis. And then I put in red, just in bottom, the way our body checks this whole system is with these Treg cells, or these regulatory T cells, which are going to make things like TGF beta or IL-10, for example, which are going to kind of help dampen down the system, because again, we don't want to turn on this immune response and let it go unchecked. So the system has ways to try to shut it off. And these chronic diseases, that system's not working very well, but this is sort of the normal response. So getting into these other types of immune response is going to help us see why they manifest so differently than our type 2 patients.
So let's bring it to the final slide, and then I have one more question for you at the end. So this is yours.
Yeah, I think this is a good example of where we start to say within the different primary responses, I'm with you. They're not necessarily maybe predominant in that they may be more characteristic, but there's a mix of things happening. As the primary driver in psoriasis, for example, we see type 3 inflammation really driving high IL-17 levels, these antimicrobial peptides. These patients rarely get skin infections, right? They get that innate protection. And then we know blocking IL-17, for example, we can see that increase with the yeast infections or candidiasis. Again, showing you the inherent value of IL-17. And the flip side with atopic dermatitis, we see type 2 inflammation really driving it, high interferon, high IL-4 and 13. We see that opposite effect where it really decreases those antimicrobial peptides. And what do we see in our atopic patients? We see MRSA, staph colonization, right? We see common skin infections.
Molluscum,
Yeah, exactly.
right?
Molluscum, eczema herpeticum, right? I always joke and say, you don't see psoriasis herpeticum, right? So there's these inherent differences in the innate protection when they get dysregulated that we start to see changes. So this becomes the clinical manifestation that we go back and say, we can kind of explain this based on the type of immune response and what's happening. So again, you don't want to separate science from being a clinician, because they work hand in hand and one should inform the other.
So I remember reading that psoriasis is heavily colonized with Staph aureus, and so is atopic skin. How come patients with psoriasis don't have an increase in staph infections? In fact, you could cut through a psoriatic plaque and they don't get infection in their joints if they're having surgery. That's because they have so much antimicrobial peptide neutralizing that. Now we understand it. We didn't understand that years ago. So, Jason, one more question for you. Okay. It's 10 o'clock, 11 o'clock at night. You've had a long day and you're starved. So you're going to leave your house and go out, right? In Portland, Oregon, places that are open late. What is the one thing you're usually going to get to satisfy that urge?
It's a hard one, but I'm going to go with a Shake Shack burger. They always hit the spot. So when I was in New York, I loved going down there, and I'm on that. If you want to have the debate on the best burger, I'm a Shake Shack burger fan.
So what is it, a cheeseburger with bacon? And any particular one?
Yeah, probably a cheeseburger plus minus bacon.
Right. So you're a Shake Shack guy. So
Yep.
if I ever run into you at the airport and I see a Shake Shack, I'm gonna treat you. So
All
Jason,
right,
thanks so much. Yeah, remember that.
Okay.
Hold me to it. Thanks so much for your time, and we will plan down the line part 2. We'll give people a little time to digest this and look at this. And I really appreciate being here today and all the time you put into understanding this, because it really helps people a lot. Thank you.
Yeah. Well, thanks for having me. Always a pleasure.
Looking for more conversations like this one? Don't stop here. Explore the full lineup of podcasts from Derm Squared, where dermatology industry leaders, innovators, and experts share insights you won't hear anywhere else. Visit dermsquared.com/podcasts.